Thank you, Chairman. Dear ladies and gentlemen, first slide, please. Within some weeks, we will start working in the GMP facility on the isolation of islets of Langerhans for transplantation in diabetic patients. Apart from the surgery department, of course, many other departments participate. The departments of nephrology, endocrinology, pharmacy, radiology, bacteriology, the transplant coordinators, and many more. Next slide. In the industrialized countries, 0.2 to 0.4% of the population is affected by type 1 diabetes, also called insulin-dependent diabetes. These patients have high blood sugar levels, high glucose, because the insulin-producing cells of the islets of Langerhans are destroyed. What are these islets? Next. The human pancreas contains roughly 1 million of these islets, purple stained in this picture. The islets are clusters of roughly 100 to a few thousand cells that produce insulin. The size of an islet is up to 0.5 millimeter in diameter. The total weight of all islets is approximately 1 gram. That is 1 to 2% of the whole pancreas. The other 98 to 99% of the pancreas produces digestive enzymes for the breakdown of our food. This so-called exocrine tissue is stained red. Light blue is the connective tissue. Next, what are the current therapies for type 1 diabetes? First, there is conventional treatment with daily insulin injections. This sustains the patient's life, but unfortunately, usually does not prevent high blood glucose levels called hyperglycemia, which, after 20 to 30 years, may cause serious complications such as blindness, lower limb amputations, or kidney failure, requiring dialysis or a kidney transplant. The overall morbidity accounts for a 1/3 reduction of life expectancy of the patient. The second option, at least for some patients, is transplantation of the whole pancreas or only the islets. Next, at present, successful transplantation is the only way to reach normal glucose control, either by transplantation of the whole pancreas or by transplantation of only the islets. Now, over 10,000 whole pancreas grafts have been performed. The pancreas is generally only transplanted together with a kidney in diabetic patients that need a kidney for renal failure. Currently, an over 90% patient and around 80% graft survival are reported. These patients have normal basal glucose levels and no insulin injections required. I will now discuss the transplantation of only the islets. Next, transplantation of only the islets after isolation from the pancreas. Why transplant the whole pancreas? Since, in fact, only the islets need to be replaced in people with type 1 diabetes. Note also that the other, so-called exocrine tissue of the pancreas is the major source of surgical complications in pancreas transplants. An islet transplant is a less invasive, safer procedure, a simple injection of 1 to 2 milliliter of islet tissue, and less costly. The islet transplant is performed in a radiology suite, where the portal vein can be visualized by CT scan. A local anesthetic is administered, and then a needle is placed in the portal vein, and the islets are injected over 15 minutes. Next, here, a schematical representation of the islet transplantation procedure. A pancreas is procured from an organ donor and taken to the islet lab where the islets are isolated. The islets are kept alive in culture for some days for quality controls and for preparation of the recipient. Then, the islets are injected in the portal vein and carried by the blood into the liver, where they lodge and start secreting insulin in response to the blood glucose. Next, I will now focus on the islet isolation procedure. Currently, islet transplantation is clearly less successful than pancreas transplantation. One of the problems is the isolation of a sufficient number of purified and viable islets from a donor pancreas. The next slides illustrate the islet isolation process, work that we will carry on in the GMP facility of the LUMC within weeks. Next, the islet isolation begins with the preparation of a donor pancreas. First, the pancreas is cleaned from fat and organs like the spleen and duodenum. Next, the organ is injected with a solution containing collagenase. At a later stage, when the pancreas is warmed to 37 degrees Celsius, this collagenase will break down, digest, the connective tissue in the pancreas that will fall apart, thus liberating the islets. For the digestion of the pancreas is placed in a chamber containing glass beads, in Dutch, kinikers, and the chamber is closed and placed in a shaker. Over here, the chamber is shaken and perfused using a roller pump with a collagenase solution that is heated in a water bath to 37 degrees Celsius. Here is a schematical representation of the digestion of the pancreas. There are two steps. First, recirculation, and next, dilution. The pancreas is in a steel chamber, shown at the number 1, with glass beads. A screen in the chamber, at 2, allows only particles less than half a millimeter to pass. The collagenase solution is pumped 3 through a heating coil, 4 warmed to 37 degrees Celsius, and recirculated 5 through the chamber. During the recirculation, the pancreas is progressively broken down into small pieces, and after around 30 minutes, when most islets are free, the recirculation and heating is stopped. Next, over another circa 30 minutes, a cold solution without collagenase is pumped through the chamber, and the suspension leaving the chamber, 6, is collected at 7. This step, the dilution, is illustrated in the next slide. Fresh cold solution on the left is pumped into the chamber. The heating coil is now out of the water bath. The tissue suspension with liberated, isolated islets is collected in the other flask. Next, this solution is centrifuged to prepare the tissue for purification. The islets are purified in a density gradient, as explained here with the tube method. Islets usually have a low density as compared to the exocrine pancreatic fragments, the so-called acini. Thus, to purify the islets from the rest of the pancreatic tissue. The tissue is mixed in tubes with a purification solution, Optiprep, with a high density of, for example, 1.1 gram per milliliter. On top of this bottom solution, a solution is layered with a lower density, here 1.09 gram per milliliter. Next, during centrifugation, the islets float to the top, and the rest of the pancreatic tissue sinks to the bottom of the tubes. Rather than handling many tubes, a special centrifuge is generally used for the purification. The coupe. First, the tissue is mixed with the bottom density solution and loaded in a blood bag. By gravity drainage, the suspension is transferred to a large centrifuge bag in the coupe. Next, while the centrifuge is spinning, a low-density solution is pumped on top of the bottom solution. Next, in the middle, a view of the centrifuge bag and the different layers while the coupe is spinning. Finally, after 5 minutes, the gradient is slowly pushed upward out of the centrifuge bag, and the purified islets are collected. On the left, a picture of the prep before purification, with the islets stained red in a sea of the other pancreatic tissue. On the right, the picture after purification. Only purified islets are seen. Next, after isolation and purification, the islets are kept in culture for circa 1 to 2 weeks, and the quality is tested before the islets are considered for a transplant. The pre-transplant quality control includes sterility testing, assessing the islet number and purity, and viability testing using specific stains that color viable cells green and dying or dead cells red or yellow. Next, around transplant time, the islet function is tested by transplanting a sample of the islets in nude mice. Nude mice are unable to reject foreign tissue. First, the mice are made diabetic by an injection of streptozotocin, which destroys the insulin-producing cells of the mouse islets. Next, the blood glucose level goes up, and at day 0, the human islets are infused under the kidney capsule in the diabetic animals. Next, usually normal glucose levels are obtained in 2 to 3 weeks. Next, here is shown the worldwide patient and graft survival of 200 islet transplants in patients that also received a kidney transplant. These data, reported by the International Islet Transplant Registry in Gießen, Germany, show patient survival is 96% after 1 year, and graft survival is 35%. However, only 10% of the recipients are completely off insulin. Next, what are the benefits of an islet transplant? Worldwide, about 10% of the recipients were able to completely stop insulin injections, and about 1/3 of the recipients benefited from a significantly improved glucose control after transplantation. Patients plagued by life-threatening reactions to insulin injections by hypoglycemia, low blood sugar levels, could benefit immediately from an islet transplant. Even islet recipients who still required some insulin after transplantation have maintained normal glucose control and were relieved of the worries related to hypoglycemia because they regained their ability to sense low blood sugar levels. This kind of metabolic control cannot be attained by insulin therapy. Thank you for your attention.